Hi, greetings everyone. I'm Dr. Krishna Priya, orthodontist associated with SCORE INCUS, and I'm helping you with your NEET MDS preparation 2023. So, we've seen a lot of topics recently for the past 2 weeks, and today we'll be covering some miscellaneous topics which is associated with cleft lip and palate, cervical vertebral maturation rates, and also some mini and micro aesthetics will be covered today. So if you guys have any questions relating to any part of the topics which I've covered earlier, kindly put in the comment section so that I can address that category separately later. And with that, with no further delay, we proceed to the today's presentation. Yes. So we'll proceed now to mini and micro aesthetics. Okay. So first question will be associated with the golden proportion. So what do you mean by golden proportion? So it was initially introduced by Da Vinci, and he has said that everything in nature presents itself in a repetitive manner. For example, the petals arranged in sunflowers and the whorls of the snail's back. So all these repetitive incidences, but in a spiral-like manner and in a proportionate with one part to other. So this is called as the golden proportion, and that is also incorporated in the dentistry on how we assess the golden proportion. So, in golden proportion can be viewed in the face. Okay, that means the distance between the inner canthus of the eye to the outer canthus of the eye, and how it's associated with the lip, the relationship between the ear and the nose, and the relationship between the forehead and the middle part of the face and the lower part of the face. So we have a lot of proportions, and in order to have a great and well defined beautiful face. So here we have also introduced that kind of golden proportions in human dentition. So generally it is concentrated along a particular ratio. So the question here is, what is the ratio of the golden proportion which is used in the human dentition? So here you are seeing a lot of values, right? So just forget everything and remember only one such thing. It is always 1 is to 0.620. Okay, it doesn't mean the size of the tooth. It only means the visibility of the tooth when you see from first. So whenever you see a person from first, you appreciate the central incisor more than the lateral incisor, and lateral incisor more than the canine, though the canine is bigger in size. So the visibility of the upper incisors or canine from outside, it is in proportions. It is in the ratio. Central incisor will be visible more. That is, one time if the central incisor is visible, the visibility of lateral incisor will be 0.620 of it. So that it is like tapering in each side of the arch. So that is what the golden proportion in the human dentition. When the proportion is maintained, then we get a beautiful smile. So it is as simple as that. So here the answer is 1 is to 0.620. You should not forget this number. It usually 618 or 620. Since 620 is closer to that, we have to chosen that value. So the golden proportion, it is referred to the ideal ratio of the width of the maxillary central incisor to the lateral incisor to the next of it. And this ratio is generally 1 is to 0.618. So this ratio is also called as the phi ratio or the divine proportion. It is found throughout the nature and art, just as I explained previously. So, with the help of this golden proportion, we can design smiles and make it appear in such a way that it is proportionate to the adjacent tooth in the ratio 1 is to 0.620. It has included almost other factors to it as well, like tooth color, shape, and alignment. So, in addition to it, when a golden proportion is incorporated in smile designing, then the result would be fabulous. Coming to the next question, negative spaces with respect to the buccal corridor is an indication of. So first you need to understand what is a buccal corridor. So let me open my pointer option. Okay. See this part, right? So this is the distalmost part of the tooth which is present, and this is the internal commissure of the loop. So this distance will be the buccal corridor space. So there is a negative space, meaning there is no tooth present in this region. So what happens is that this buccal corridor space, negative space, is also an indication for the expansion which is possible in this direction and also in this direction. So whenever you see the buccal corridor space, it is generally a transverse kind of condition. Like, so what kind of movement can be done transversely? Expansion can be done. So the answer here would be expansion of the arches. When it comes to intrusion, it won't optimize, it won't be using the space in an optimal manner, but constriction of the arches will further worsen the given scenario. So the expansion of the arches will be the right answer for this question. Yes. And in most of the conditions, it may also be an indication for the expansion to take place. Which of the following is seen in anterior deep bite? So first of all, we need to understand what is an anterior deep bite. It can be because of two reasons. One, the upper tooth, right? So imagine this is the upper tooth and this is the lower tooth. Deep bite will occur when the upper tooth is extruding so much, okay? Or else it may also occur because of the intrusion of lower incisors or the posterior teeth, right? It is present in a such manner that there is a deep bite here. So it can happen because of combination, either extrusion of the upper incisors all altogether or intrusion of the posteriors or combination. So here in an anterior deep bite case, um, the given options are upward pitch of maxillary occlusal plane, downward pitch of maxillary occlusal plane, right side roll, left side roll. The roll here corresponds to the vertical or anterior posterior scenario, but we are talking about the pitch here. So deep bite is a vertical condition. So the pitching of upper jaw downward manner will actually lead to the anterior deep bite. So the answer would be downward pitch of the maxillary dental plane. And one of the common challenges seen in the anterior deep bite is actually downward pitch. This means that the angle of the occlusal plane will be like this. So it makes an acute angle and thereby the deep bite worsens. And it is also very important in changing the orientation of the maxillary occlusal plane. We have to correct the downward roll of the downward pitch of the maxillary plane by intruding the maxillary arch as such using skeletal anchorage systems or TATs. So that is one of the treatment plans for deep bite, but generally it is occurring because of the downward pitch of the maxillary occlusal plane. So coming to the next question, the orthodontic diagnosis and treatment of focuses on. So basically, why do patients come to us? Generally, they want their smile to be aesthetic and their smile to be pleasant, or else they'll be complaining that they're not so much confident because of their smile. So uh, what values will help in identifying the nature of the patient's smile through diagnosis and treatment plan is what we are going to discuss here. See, smiles are of various types. There is a Mona Lisa smile, okay, that is called as the commercial smile, where the patient won't show their teeth at all. The second is there is a social smile, that is the reproducible smile. The patient won't smile fully, but they would have that posed smile wherein they repeat the smile again and again consciously. And there we have a complex smile, which is the spontaneous smile. So this the patient can't control this smile. So how to identify between a social smile or a posed smile and a spontaneous smile? So in a spontaneous smile, as Ackerman says, the whole involvement of the face will be seen. For example, in a spontaneous smile, we just try to smile all together. The expression will be seen on the face. We can identify the wrinkles near the eyes when we like fully smile, and also the muscles in the cheek will work. But when you look at a posed smile like this, there is no movement or activity of all the muscles in the face, right? So that is the difference between a posed and a complex or spontaneous smile. The commission of Mona Lisa smile is very easy to identify because no teeth will be shown there. So with these three pattern as an identification mark, the orthodontic diagnosis and the treatment plan focuses on social smile because that is the most reproducible smile by the patient. So we focus on that smile to do an orthodontic treatment plan. So there are two pictures shown below. I'll be showing the pictures. According to Ackerman classification of the normal spontaneous smile or posed smile. As I mentioned now. So the downward is obviously a spontaneous smile because it is shown in her whole face. Can you see the nasolabial fold is involved and she is expressing it throughout her face. But in a posed smile, it is just concentrated only in the lower part of the face. So it is very easy to identify a spontaneous smile with the posed smile. So the answer one will be the part one. That is the first picture is a posed smile, whereas the second picture is a spontaneous smile. Yes, and spontaneous smiles also tend to be symmetrical and involve both sides of the face equally, while posed smile will be asymmetrical because patients usually believe that one side of the face is more aesthetic or more proportional when compared to the other. So they tend to focus more on that side and they smile in such a way that their proportional face is expressed. So it may tend to be asymmetrical also. Next question. The term macro aesthetics refers to, okay, we are going to classify which comes under what. So first is macro aesthetics. So what do you know by the term macro? Macro means it is a bigger subject. So in macro aesthetics, imagine we covering everything from profile, vertical proportions, lip fullness, chin and nasal projections, and also the facial width. So something which is associated when a patient is presented to us as a whole face. That comes under macro aesthetics. What does mini aesthetic stands for? So mini aesthetics is the incisor display, transverse smile, smile asymmetry, crowding, and a smile arc. So mini aesthetics is something which focuses more on the lower part of the face. Okay. And what is micro aesthetics? Micro aesthetics is something which focuses even more keen on to the tooth. For example, the gingival shape, margins, emergent profile, tooth shape, and also tight contacts and embrasures. So we are just focusing from outside to inside. Macroaesthetics, mini aesthetics, and microaesthetics. So you have to understand this to answer a lot of questions under the same genre. The term macroaesthetics refers to smile framework, the teeth, tooth proportion, the face in all three planes of space. So the answer would be face in all three planes of space. We'll discuss this thing. Mini aesthetics in orthodontics means what? So mini aesthetics is, as we already discussed, teeth in relation to one another, facial to body proportions, facial proportions in all three planes, the dentition in relation to face. So the answer would be the dentition in relation to face, because we are not only concentrating on the teeth alone, that is micro aesthetics. On face alone will be macro aesthetics. A combination of these two, that is the lower tooth to the face, it will be considered as the mini aesthetics. In a systematic examination of facial and dental appearances, mini aesthetics include the assessment of, just now we said, mini aesthetics. Okay, don't confuse it with micro. Tooth shape, excessive or deficient facial height, gingival shape and contour, inappropriate gingival heights. So the third option would not be choice here, but inappropriate gingival heights is correlating with mini aesthetics. Okay, because excessive or deficient facial height will come under macro, tooth shade and gingival shape and contour will be coming under micro. So the inappropriate gingival heights will be seen when a patient smiles, right? So that will be coming under mini assessment. Okay, mini aesthetics in general will look into the facts of assessment and appearance of the dentition in relation to the face, which will include the tooth color, shape and size and position, as well as the relationship between the teeth and the surrounding soft tissue. So in the systematic examination, mini aesthetics includes the assessment of various things also. The height of the gum tissue around the tooth can also affect the appearance of your smile, as I already mentioned. So I evaluate the gingival heights to determine whether any corrective treatment as crown lengthening is essential at the end of the treatment in order to improve the appearance of smile. So it will correlate to that. Now coming to the next question, the cant of maxillary occlusal plane in transverse direction when seen facially. So you should really understand the importance of this question. When you know the concept, you can answer a lot of questions in a similar genre. So, okay, here I have given a picture of a face, okay, and I've split it into three. You can understand one, it is an anterior posterior. That is when you see the face from this side, it is a profile. From here, from the nose tip till the back of the mind, it is the anterior posterior. Only in the anterior posterior direction, you can talk about retraction of the patient anterior tooth or protraction of the patient's tooth. And the other one, transverse, right? The transverse is the one in the yellow. So transverse will be something in this direction of cutting the face like this. So in transverse direction, we'll mostly be talking about maxillary expansion, things like that. Okay. And another one is vertical. In vertical, we'll be talking more about the downward movement and upward movement, how the tooth is intruding or extruding. So based on these dimensions, we will be talking about three terminologies. One is pitch, one is roll, and one is yaw. So, since the action of the tooth doesn't actually correspond to the dimension it is presented, so I'll be very clear with this. First, we'll be talking about anterior posterior. In anterior posterior, it will have the terminology which is pitching up of maxilla and pitching up of maxilla and the pitching down of the mandibular maxilla as such. In transverse correction, we'll be talking about rolling of maxilla on one side or the other. And in the vertical correction or occlusal correction, we'll be talking about yaw. So usually associate each plane with a particular terminology here. So anterior posterior would be pitch, transverse would be roll, and vertical or occlusal will be yaw. So here, the cant of maxillary occlusal plane in the transverse direction. So we are talking about transverse direction here. When seen facially will be roll. Because transverse occlusal plane, it is associated with a term called roll. So when you understand this concept, then you can answer a lot of questions. So the maxillary occlusal plane may tilt or roll to one side of the other, so resulting in an asymmetrical plane. So as I said, transverse is usually associated with the maxillary expansion or constriction. So whenever there is a tilt on one side or the other, then from front appearance, it will be asymmetrical. One side the gingival height will be more, the other side it will be less. So in that condition, we have to correct it again. So the correction with the help of these terminologies as pitch, roll and yaw, we can identify with a particular dimension the problem is, and then we can correct it. So pitch refers to the angle of the occlusal plane, that is front and back direction, while yaw refers to the angle of occlusal plane, which is relative to the vertical line. To summarize, when the cant of maxillary occlusal plane is seen in the transverse direction, it is referred to as roll. Just need to associate pitch, roll and yaw with the anterior, posterior, transverse and the occlusal plane. That's all. So coming to the next question, the gingival height of the contour is also called as. So what do you mean by the gingival height of the contour? So the gingiva, it drapes over to the tooth, wherein we have the highest position of the tooth and the adjacent downward area. So the highest position of the gingival height on the contour is called as the gingival zenith. So that is marked here with the yellow point. Highest point of the gingival tissue surrounding the tooth. And what do you mean by gingival apex? So it is not used in orthodontics or dentistry in general, but it is confused with the tip of the tooth, but it is not a terminology generally used. It's gingival zenith. What do you mean by smile arc? We were discussing about the smile arc, right? But that is a curvature of the upper incisor tooth with respect to the upper part of the lower lip. So when the upper tooth coincides with the lower lip, then we can identify the smile arc, and it is divided into consonant smile arc and non-consonant smile arc, which we'll be discussing later. So the gingival height of the contour generally refers to the zenith. It's also called as gingival zenith. So now, yeah, this is the smile arc I was talking about. It can either be straight, consonant or non-consonant. So identify with this picture. Okay, it is very similar to the consonant smile arc. You can identify a consonant smile arc when the upper incisors, right, the lower border of the upper incisor coincides with the upper border of the lower lip. So when it follows the upper border of the lower lip, then it is called as the consonant smile arc. If it doesn't, then it is called as the non-consonant smile arc. Or sometimes when it is so straight, it is called as straight smile arc. So here the diagram represents the consonant smile arc. Coming to the ratio of the width to height of maxillary central incisor is. So the golden proportion is different. Golden proportion is something which is visible to the naked eye from the front while seeing a patient smile. So here they're asking about the ratio of the width to height. Generally, in an average, the maxillary central incisor would be 10 mm in height, whereas 6 to 7 mm in width. So when you divide the width by height, you'll get somewhere around 0.6 to 0.8. But always 0.6 is ideal. So we go for the ratio of the width to the height of maxillary central incisor would be 0.75 would be ideal, but closer the ratio of 0.6 corresponds to the narrower central incisor, which may appear more feminine or youthful, while a ratio of 0.8 or higher may create a more masculine appearance. Because usually the facial type also decides the shape of the tooth. For example, if you have a dolichocephalic or a long face patient, they would be they will tend to have a more longer and narrow central incisor. But when you take a brachycephalic, that is like wide angled and wide chubby face, then they would tend to have a wider tooth, wherein their ratio would be somewhere around 0.8, but in a first condition it will be around 0.6. So it also depends on the facial type of the person as well as the tooth shape and size. Smile when viewed from front is considered to be aesthetically pleasing. F. So here they've just given it in percentages, I guess. So each tooth in that smile starting from midline is approximately 55% of the tooth immediately mesial to F. So I think only the percentage changes here. 55, 60, 65, 70. So according to the golden proportion, it should be around 60% because the ratio is 1 is to 0.618. So it comes up to 60%. So that will be the answer here. Yes. So 1 is to 0.618, and when you see in the mathematical ratio, it is actually 1.618 times the previous. So if you calculate it, then the ratio would be around 60%. Percentage will be around 60. Okay, so with that, we've completed micro, mini, and macro aesthetics, and also questions with respect to smile arc or golden proportions and such. Now we are moving on to cleft lip and palate. Infant orthopedic treatment done at an early age because of. So, okay, whenever you are looking into cleft lip and palate, some of the important questions may be associated with the classifications, Kernon's Weisstrip classification. But now we'll be seeing questions which involves at what time, the timing of the surgery. Okay, in cleft lip and palate patients, generally you should understand a few situations. Cleft lip generally means that the patient's fusion of the maxilla and also the nasomaxillary complex will be limited. So during birth, there would be a cleft in the region. So immediate intervention is necessary for the patient to undergo feeding because they have to create a negative sucking environment for the food to enter through their mouth and go into the esophagus rather than going into the breathing tube. So, in order to create that negative sucking environment for the patient, we introduce something called PNAM. I'll be putting a picture later, but PNAM is nothing but pre-surgical nasoalveolar molding. So, we are creating a temporary division between the nasomaxillary complex, like as a base of the nasal bone and also as the roof of the maxilla. So when we introduce such thing, then it will be very helpful for the patient to gain the nutrition the patient needs. So only when we do that, the later stages, this sucking pressure will in turn be helpful in the development of maxilla and the oral cavity and the nasal cavity for the patient. Okay, so keeping all this in mind, in this topic we'll be discussing about at what age surgery should be done to the cleft patients, starting from pre-surgical nasoalveolar molding, it is also called as PNAM, and also the cleft lip surgery, when it should be done, and what is alveolar grafting. So alveolar grafting is something because, see, in cleft region there is an incontinence. Okay, there is no bone at a particular level, a particular area. For example, the normal lip will be like this, something like this. But in cleft, okay, this region is gone. So the bone associated with this region will be gone. Therefore, usually cleft patients will be having a missing lateral incisor or canine associated with it. Why? Because when the bone present in this region is not there, bone is definitely required for the tooth to erupt into. Okay, bone is a must. So in those cases, when we intervene early, then we are proceeding with the bone deposition there using a bone graft material, and will help in the tooth to erupt through the bone. Okay, so that is called as primary alveolar grafting, and we also do that for the second time because at the age 8 or 9, the canine develops. So canine also requires certain bone to be placed there so that it can pass through the bone and come into the oral cavity. So the secondary alveolar bone grafting is done at the age before 7 years and also in the initial stage for the development of lateral incisor into the particular area. So we are going to see more about cleft lip surgery, PNAM, and primary alveolar bone graft, secondary alveolar bone graft when it comes to cleft lip and palate. Okay. With that in mind, let's proceed to this few questions regarding cleft lip and palate. Infant orthopedic treatment done at early age. Why it is done? High blood supply, increase in the level of growth hormone, due to the increase in hyaluronic acid, tranexamic acid. So it is definitely not growth hormone or blood supply. It is mainly because of hyaluronic acid. Let's see why. So hyaluronic acid is a very natural component of the body that is present in very high levels in infants, and this is very essential in the formation and maintenance of healthy cartilages and bones. So for the bone development to take place, and it's very essential to do an infant orthopedics at an early stages of life in the cleft tissue. So coming to the next question, infant orthopedics in a cleft patient is done at the age of. So what is the particular age wherein we intervene with the cleft orthopedics? It is 3 to 6 weeks. Okay, in 3 to 6 weeks, we intervene primarily with the PNAM, and this is called as the nasoalveolar molding. So basically, we just provide a division, and we also close the gap so that the patient may undergo the nutrition it requires. The ideal time is intervention of the infant orthopedics is around 3 to 6 weeks of age. And why this age? Because early orthopedic treatment can help in minimizing the impact of cleft on the child's facial structure, speech, and overall development. And it is also easier for the manipulation and the correction. NAM involves the use of specialized oral appearance, which I showed earlier, right? Which had a stent and also an acrylic plate into the correct alignment. So, pre-surgical orthopedics, on the other hand, involves the use of braces or other devices to help align the infant jaws and other facial bones in preparation for the surgical correction. So, this PNAM or nasoalveolar molding, it is done initially so that it acts as a framework so that we can act on it using future orthopedics intervention. A repositioning of the premaxilla is a must before the cleft lip and palate surgery as it. So why it is the reposition of premaxilla essential? Why? It supports base for lip suture, helps in feeding, helps in proper alignment of permanent central incisors, helps in preventing speech defects. So the third option is gone because the permanent central incisors comes only at the age of 6 or 7, which should be very late for the correction of the early intervention. So basically, the answer would be supports base for the lip suture because lip surgery is also introduced earlier because of the correction and the development of the patient's face. Therefore, the repositioning of the premaxilla is done, and it must be done before the lip surgery because it acts as a support for the lip suture. Yeah. And the premaxilla is a portion. So what it includes is upper jaw that contains only the central incisors and often displaced in patients with cleft lip and palate. So repositioning will help in to support the base for the lip suture during the surgery because it directly is the lip is actually related to the central incisor for its support. And during the surgery, the premaxilla is repositioned and held in place with other devices so that we provide a support for the upper lip for the suture. And it can also help to improve the appearance of the patient because we provide an increase in the level of positioning of premaxilla. Therefore, it will help in improving the profile appearance as well. So, in summary, it is actually mainly done for the providing support for the lip suture. Surgical closure of cleft lip is usually performed at what age? So again, we come to this question. So initially, we were talking about NAMS at around 3 to 6 weeks, and now this will come under 2 to 12 weeks. So surgical closure of cleft lip is performed at the age of 2 to 12 weeks. Everything is done priorly in order to improve the development and also improve the function and aesthetics of the patient. Yeah. So the tissues of the lip are still relatively pliable and can be easily manipulated to achieve optimal surgical results. Surgery of the cleft lip should be carried out at what age? So 20 to 30 weeks, 2 to 12 months, 3 to 6 months, or 5 years. It should be around 3 to 6 months. So the entire cleft lip and cleft lip surgery and the preparation would be done before the 6 month week because it is a critical aspect of overall treatment of patients with cleft lip and palate. And optimal timing usually depends on a lot of factors, including the age, overall health, and current development of the patient scenario, and also the extent of the cleft. Not every patient would be present with certain cleft condition. There are a lot of different classification on how much the cleft is affected the patient. It can be only in the lip area. It can only involving the primary palate, or it can go until the whole secondary palate as well. So it depends on the classification or the complexity of the cleft involving in a particular patient. But generally, it should be done before between the 3 to 6 month period. So yes, alveolar bone grafting. I was talking about this because bone is very essential for the tooth to come down into the oral cavity, and it is done in the cleft palate patients. The order of sequence is what? After the maxillary expansion and correction of crossbite, and before the eruption of canine. After the eruption of the canine, or again before the eruption of canine and after the correction of the crossbite. So they've given a lot of different scenarios, but the correct option is, when can we do bone grafting? Only when we achieve the proper maxillary expansion. Okay, when we achieve the proper maxillary expansion, then it will automatically correct the crossbite. So when the crossbite is also corrected, everything would be in proper occlusion with each other. So this will be the right time for the bone grafting to be done, so that there will be enough space for the tooth to come through the bone. If it is done before the expansion or before the crossbite correction, then there won't be any sufficient space for the tooth to come out. So expansion by itself corrects the crossbite, and thereby that will be the apt time for the bone grafting to be done. Also, it minimizes the risk of damaging the developing permanent tooth. It's how this bone grafting is done. It's typically harvesting bone from another part of the patient's body, such as the hip or ear crest, and transplanting it to the area of the cleft. And this grafted bone is then held in place with screws or other hardware. So the patient is monitored so closely that whenever it is taken up, that the patient won't suffer any other damage because of this. And during healing process, we have to cautiously look over the entire procedure. Eventually, after the bone grafting, when the tooth comes out through the bone, we would require an orthodontic intervention like braces or the alignment of the teeth as a finishing procedure, because the eruption of the canine, since we are doing it with the presence of grafting, we are not very sure of the positioning of the canine. So in order to bring it to its optimal position, braces may be required at the end of the treatment. Primary alveolar bone grafting is done at what time period? It is done before the age of 2 years, as I was mentioning earlier. Secondary alveolar bone grafting is done for the canine eruption, that is done around 7 to 8 years of age, but primary it is done before the age of 2. When the patient's growth potential is still high and the tissues are more responsive to surgical interventions. So this also involves harvesting the bone from one part of the body and then transplanting it to this area in order to for the development of the tooth through the bone. So following the procedure, the patient may require additional interventions like orthodontic treatment. False about secondary alveolar bone grafting is. So let's look at the options. Allows and supports the spontaneous eruption of the maxillary canine. Yes, it does. Grafted bone in case of missing maxillary lateral incisor does not provide a good site for the implant. Maybe. Helps closure of the oroantral fistula. Yes, it definitely does. So what is oral antral fistula? It is the connection of the oral cavity and the nasal cavity, uh, which will act as an inflammation or infection point in the longer run. So, because of this alveolar bone grafting, and the bone is preventing the formation of the fistula, and therefore it really helps with that. Helps in stabilization of maxillary segment before orthodontic surgery. True, because this bone grafting will help in the formation of a bone and through which the tooth comes in, and therefore it also helps in stabilizing of the segment. So, what is false here? Grafted bone in case of missing maxillary lateral incisor does not provide a good site for the implant. It actually does, because doing the alveolar bone grafting will in turn help in the development of bone so strong that in the later stages we can also put an implant when there is a missing lateral incisor, which is usually the case with respect to cleft lip and palate. So the benefits actually improved support for the upper lip, improved facial appearance, improved speech development, decreasing in the occurrence of oral antral fistula, and also it will help in stabilizing the maxillary arch before any orthodontic surgery, and it also helps to ensure any future surgical interventions can be carried on because of the presence of bone. So yes, the most important reason for placing an alveolar graft in a cleft palate patient is improve pronunciation, breathing efficiency, make eruptive pathway for the permanent canine, improve feeding efficiency. So see, look carefully here. Secondary alveolar graft, if that is asked, then we have to definitely go for permanent canine. If the question is about the primary alveolar graft, then we have to look into the maxillary arch development and options similar to that. So here the question can also be a little tricky. Kindly pay attention to that. Yeah, we've been discussing this so far. So the last topic of today would be cervical vertebra. So how come the cervical vertebra is used for identifying the age? So I'll be very quick in addressing it. You just need to remember 6 things. Okay. So what is cervical vertebra? Usually when we take cephalometrics for the patient, which is a supplemental diagnostic aid, we look into the C1, C2, C3, and also C4. So the most importance will be given to C2, C3, and C4 vertebrae. Okay. So when by identifying the position of the C2, C3, and C4 vertebra, we can guess at what stage of growth the patient is, and so that we can calculate and how to use that growth potential towards the treatment. Okay, first I'll explain the process and then we'll go deep into at what stages what treatment can be done. So first an initiation, okay, when it is mostly about the lower surface of the vertebra. If the lower surface is very flat, like straight, then we can see that almost 100% of growth potential is there. We can make use of the growth potential. And the second stage is acceleration. So here there is slight concavity in the C2 and C3, but the C4 will be flat. So in this case, we have 80% of the growth potential remaining. And in third one, it is called as transition stage. So here, the C3 and C4 will be somewhat in rectangular shape, and C4 also develops a concavity. So about 60% of growth potential is still there. And fourth will be deceleration. Here, almost distinct concavities will be developed in C2, C3, and C4, but from rectangle shape, the C3 will become more of a square shape. Okay. Here, only 40% of the growth potential is remaining. Maturation, insignificant amount of growth is actually expected. That is, the C3 and C4 are almost square shaped, and accentuated concavities is developing under C2, C3, and C4. In this case, only 20% of the growth is remaining or left. In completion, 0%, the growth is actually completed. So how we can indicate is that there will be marked concavities in C2, C3, and C4, and C3, C4 are greater in heights than width. So this is a simple thing. So with the help of only C3 vertebra, whether it is flat, mildly concave, rectangular, square, or the height is more, we can identify how much of growth is left for the patient so that we can intervene. Here, since we all know maxillary growth completes earlier, okay, so basically when the patient is in CVMI stage 2 or 3 or 1 or 2, we'll go for maxillary protraction using face mask. So usually class 3 corrections can be done in CVMI stage 1 and 2. When it comes to mandible, class 2 condition, right, we need a growth potential for the mandible to come forward. So in condition like that, we can make use of the CVMI stage 2, 3, and till 4. In 4, usually we use fixed functional appliances, but in CVMI stage 2 and CVMI stage 3, we may use mandibular advancement appliances. So using these maturity indicators, we can actually play with the treatment planning in the long term. Yes, this is what I'm talking about. C2, C3, and C4 are usually used to identify how much of growth potential is left in the patient, and each stage is given a particular name like initiation, acceleration, transition, deceleration, maturation, and completion stage. So, with this knowledge in hand, let's proceed to the following questions. The use of cervical vertebra as skeletal maturity indicators was first done by Lampersky. So Lampersky was the person who first initiated it, but later a lot of people gave their own system of classification, and now we most commonly use Singer's method or Hazel and Farman method. But it was first given by Lampersky. Yeah. Hazel and Farman have since refined the staging of cervical vertebral maturations, and also they proposed modifications to the initial staging system. With the maturity of skeleton, all of the following events takes place at C2 to C4 except the shape of bodies of C3 and C4 vertebrae change subsequently from wedge to rectangle. With the maturity, the concavity at the inferior border decreases and becomes flat. With the maturity, the tapered superior border becomes flat. The bodies of C3 and C4 were square or were greater in vertical dimension than in the horizontal dimension. So the answer would be B, because the remaining actually suits with the maturity. But with the maturity, the concavity increases. It doesn't become flat, as we've already seen. So the option B would be the wrong one here. Skeletal growth completion can be assessed by the cervical vertebra by following findings. Let's see what it is. The vertebra were wedge-shaped and the superior vertebral borders were tapered from the posterior to the anterior. First one. Second one will be the bodies of C3 and C4 vertebra were nearly rectangle in shape and taper at the superior border posterior to the anterior. They just taper like this. The bodies of C3 and C4 are nearly square. So square in shape, the inferior borders becoming flat. The bodies of C3 and C4 were greater in vertical dimension than in the horizontal dimension with deep concavities at the inferior border. So growth completion can be assessed only by D because in the end it has some deeper concavities and they are more in the height when compared to the width. So the answer D suits the given question. Of the following as signals which can be used as a skeletal maturity indicator. So till now we will be seeing about the C2, C3 and C4 utilizations for skeletal maturity indicator, but also the frontal sinus can be used as a SMI. Okay. Yes, by taking up the measurement, okay, here can you see from sella turcica? Sella turcica is the S which is given here till the nasion and identifying the frontal sinus width which they have given, right? They have marked 4 points and they've given the frontal sinus width. So based on the measurements, they've also calculated by quantification value, they've calculated the skeletal maturity indicator for the particular patient. But for this, we need three-dimensional radiographs like CT or CBCT. And one of the common most methods for identifying the skeletal maturity indicator using the frontal sinus development is the Grulich file method. So X-ray of the hand and wrist along with the measurement. So they compare the sinus measurement along with hand and wrist radiographs. So in order to assess the bone age of the particular patient. In assessment of skeletal age based on cervical vertebra seen in the lateral cephalometric, stage 3 indicates. We're talking about that, right? Initiation, acceleration, transition like that. So what does stage 3 incorporate? Less than 1 year prior to pre-growth. As I was saying, the percentages required like 100% of growth left, 80% of growth left, like that. We have a particular stage called puberty or peak growth. It will be there for each patient. So the peak growth usually is around C2, second stage, and or third stage. It may be even different aspects with different patients. So generally, stage 3 indicates less than a year to the peak growth. Okay. So as I was already suggesting, there are 6 stages with stage 1 representing the early development and stage 6 representing the maturity. So stage 3 is known as the inflection point. So it is characterized by the indicating that pubertal growth spurt is just about to begin and the individual is less than 1 year prior to the peak growth. Now we are moving on to the ortho interrelation. There's some miscellaneous questions. Tooth movement in pulpless teeth compared to vital teeth. So you know, right? When we do an RCT in a particular tooth, so they're just asking how come a natural tooth moves when compared to the tooth which is done RCT? The answer is the same because we are giving the same amount of force which is distributed to the PDL. Doing an RCT doesn't increase the movement or decrease the movement. Yes. In summary, the movement of tooth in response to orthodontic force is the same in both the pulpless and also the vital tooth, but other factors also may be useful in identifying the rate of the tooth movement. The recommended period of observation prior to orthodontic therapy in case of trauma involving the crown root fracture without the pulpal involvement and concussion are. What they're asking is the pulp is strong, okay, but the tooth has undergone a fracture. So, how much days or time we have to wait before an orthodontic therapy to be done? The answer would be 90 days. We have to wait till 90 days because whenever a force or trauma is happening to the particular tooth, the PDL fibers associated with that tooth will be enlarged and there may be some inflammation around the particular tooth. We need that inflammation to subside because whenever we give the force again to the particular tooth, then it may cause a resorption or internal resorption may occur around the tooth, which may not be beneficial for an orthodontic treatment. So we have to wait for 90 days after endodontic therapy to proceed with an orthodontic treatment in case of trauma. Minimum time period before attempting an orthodontic treatment in a tooth with unfavorable root fracture. So it will be 2 years because the greater the complexity of the root fracture or crown fracture or the pulp involvement, the greater time should be taken for us to start with an orthodontic treatment because we are not only including the tooth here. We are talking about the PDL fiber associated with the tooth and it is association with the bone. So the longer we wait, it is better for us because the bone would be formed, the inflammation would be settled, and then we can start with resorption and deposition simultaneously. Tooth fracture in the coronal or middle third, time required to wait before an orthodontic treatment. So how much time is required here? A, that is 3 months because it is only in the coronal or the middle third. So the time required to wait is 3 months. Only when it is going up to the root, then we have to wait for almost a period of 2 years or even 9 months after an endodontic therapy. But here in the coronal root or middle third of the patient, if the tooth is fractured, then we wait for 3 months. So with this, we come to the end of. So with this, we come to the end of today's session. We've covered a lot of topics today. So starting with microaesthetics or macroaesthetics and be it cleft orthodontics, and we were covering about skeletal maturity indicators and the effect of endodontic therapy in orthodontic treatment. We've covered a lot of topics today. So I think after this, we'll be proceeding with individual topic questions. So any doubts, if you have regarding the session, you can let me know, or you can put up in the comment section so I can address it accordingly. Thank you and have a great weekend. See you in the next class. Bye.